Let's see. I'm sharing the screen. Okay. Can you see me now?
We can see you and the slides now. Thank you. Go on.
I think you have a lot of thing here. Let me see. It looks like there are too many things on the top there, but whatever it is, are you seeing my presentation?
We can see your presentation and also your face, and that's great. You can go on.
Okay. So I'm going to talk to you about lung. This is actually Mount Sinai Hospital in New York City. And as you can see here, this is Central Park right here in the reservoir. And this is our medical school. And you can see this building around here on Mount Sinai. It's on Fifth Avenue. And you're all actually welcome to come and visit. It's a very interesting place. New York City, look at New York. This is Central Park. Those buildings here, show you later, they're like all 22 floors, 25 floor building. This is the Plaza Hotel, and here is the Trump Tower, where President Trump live when he come to New York. And what happened today? Take a look. This looks like a miniature building here now. They're all building these towers, very thin, but they are like over 100 floors each. And the city is filled up with all this kind of high rise. So this is New York, actually last year, November. This is New York in normal time, rush hour, Friday afternoon. A year ago, that's before the COVID. And as you can see, you can walk on the sidewalk. So what happened with the COVID actually, because if you can see those people here, there are 75% of them are tourists, and the rest are all these offices building that now people don't come to work anymore in the office. They all work from home. So as the result of it, there's no tourists today. Nobody's come to New York. Nobody's traveling really. And nobody come to work in Midtown. So this is New York last week. I was just driving on Fifth Avenue. And look at this. This is Fifth Avenue. This is Fifth Avenue. This is St. Patrick Cathedral, just next the front of the Rockefeller Center. You can drive with no cars around, very few people. This is Versace. Usually you can't even see the store from all these people. It's all empty. This is Radio City Hall, famous place where they do all the shows. No one is there. In fact, look at the Hilton, that is always packed with people. They closed it. Just all wood covering all the stuff there. So the city is totally transformed in this time. Unfortunately, hopefully things will get better. So let's go to our job today, talking about lung regeneration and lung engineering. There are two different things. So I'll start talking for one. So as you know, the lung basically, of course, alveolar and the pulmonary, and all this exchange of gas occur in a normal lung in about 100 square meter area. If you take one lung of a normal person, it's about the size of a tennis court. And what happened with emphysema, there are 65 million people around the world that have emphysema and COPD, 60 million in the US, and there are about 30,000 with cystic fibrosis. So all these people have destroyed, basically, if you look at their alveoli, they're all destroyed. And once they destroy all the damaged alveoli, they really cannot provide the usual surface for airway exchange. And you can see here, normal lung, and here too, you can see how those alveoli are all destroyed. Now, the point is that this destruction is permanent. There's no cure to it. It wouldn't go back. So, and once you reduce this area, the surface of gas exchange, you going to be in, you compromise the lung mechanic, the lung is hyperinflate, you get hypercapnic, hypoxic, there is dyspnea with limitation of airflow, and the patient obviously debilitated and required therapy, oxygen therapy at the end, and sometimes tracheostomy, and so forth. This is to show you that the lung with emphysema, unfortunately, would not be regenerated. So what can we do for those emphysema? Well, really, we can't do much because medical therapy is usually doesn't just basically palliative. It doesn't really give you much. You can give steroids, you put on bronchodilators, and so forth, but it's not going to cure them. They can just delay the process, the progress of the disease. Now we do lung volume reduction surgery, which actually, it's kind of stopped doing it since the study, the famous study that was done about emphysema, that is not really helpful. But we do a lot of endoscopic lung reduction, meaning putting like glue, coil, thermal, and valves. Use different valves that are approved, like aspiration valve and so forth. Recently approved in the United States, not only for air leak, but also to reduce the area that is wasted ventilation, where the bulla is. But the definitive therapy for the emphysema is lung transplant. That's the only definitive one that can happen. However, it's a problematic because, as you know, organ availability is very limited. So one exciting issue is lung regeneration and lung bioengineering. And I think what was like is science fiction, it's several years ago, now maybe it's becoming reality in the foreseeable future, close by. So let's start to go over this a little bit. So the lung has basically about 30 type cells in the lung, just like make clear that we're not going to talk about all this. You'll need, more than that. The basic structure of the lung, beside the capillary endothelium and stroma cell and macrophage and so forth, the type 1 cells that are cubital, this cell that you see here in blue, I mean in green, this is the development, but the ultimate production is the green one. Those are the type 2 cell that are responsible to secrete the surfactant protein that allow the lung to expand. And type 1 cell are those really the cells that do all the work. Those are flat cells that are really cover all the lining of the alveoli, and those are the, you see in red, and those are the ones who are responsible for the gas exchange. Now, and when they develop to the final product, they start from a epithelial progenitor cell. And those is very important because those cells give, birth to type cell 1 and type 2, both of them. And then they got alveolar stage. This is the saccular stage in development. Alveolar stage is differentiation to be mesenchymal cells, and then we get the final product with type 2 cell in blue here and a type 1 cell. It is interesting that we know now the type 2 cell, the cuboidal cell, can proliferate and give rise to type 1 cell. So they're like our certificate of guarantee. They can regenerate and transform into type 1 cell. Those cells that really keep all the gas exchange. Again, those alveolar epithelial progenitor cells that I told you before, they can go either, they have the capacity to transform in type 1 or type 2 cell to do that. So the important is to identify those mechanisms, this factor that can modulate the stem cells to transform into into type 2 cell, and they can there transform into type 1. And there, if we can give those cells through an injection, they can go to the lung and they will regenerate part of the lung that is destroyed in case like of emphysema or in any kind of COPD. So here it is, either it's emphysema or fibrosis. They can just regenerate again and modulate it to transform into cells, into structures to fill the area of defect in the lung. Now, if you can see here, it's organoids. Organoids is something that you should be familiar with because this is one of the most exciting research in future. And their organoids are isolated from tissue, and they can conserve the progenital capacity. In other words, they're like three-dimensional. There's three-dimensional structure that conserve the ability and capacity to transform into whatever cell you wanted to derive from. It can be type 1 or type 2 cells. Now, this is the organoid. This is a lung organoid that it grows from lung tissue. And those are not injected, they are transplanted into the lung to where you want to put it. This is another type of organoid. Now, those organoids are self-assembly structure, and they get generated from this epithelial progenitor, and they can populate. You can populate them into the lung, transfer them into the lung, implant them in the lung, and they will transform into type 1 or type 2 cell. And we might be involved in this in the future, like in the bronchoscopy suite, to transfer them into the lung, if needed, like we do today with endoscopic lung volume reduction. Now, there are many organs derived from human tissue, as we said, and as I told you before, there are cells that assembly and very close to the alveolar structure. So what is it, what's so good about it? Well, you can take this organoid, if, for example, with the COVID, there are about 1,200 drugs, medications that try to see if they can block the COVID virus. So you can do those experiments on the organoid. You can also take drugs that are already approved by the FDA, right? And you can look if those drugs can be speedily confirmed or approved by the FDA or not. But you do it on the organoid rather than go around and spend a lot of resources. You can do it in a very controlled manner. For example, we know that we want to screen for COVID, right? So you know that the SARS-CoV-2 infect the airway, correct? And the way it works is work on the angiotensin converting enzyme type 2 receptors. So there where the virus attached, and that's the way infect the human cell. And one of the cells that they infect is a type 2 cells. Those are the cells that we need to, in order to transform to type 1. So if the virus attack them, and through attaching to the angiotensin conversion enzyme type 2 receptors, that's where we need to see how we can block it. So if you look at here, this is an organoid. This organoid is it's a lung organoid, and you can see here in red, all this like in red or right here, you can see those are the type 2 cells right here. But if you look at the green part, see this green cluster here, those are the angiotensin converting enzyme type 2. that are the receptors of the SARS-CoV-2 virus. So you can take the organoid and do all your experiment and all your research concentrated on one type, on one area, and you can speed up your process. So this is one of, there are organoids of many, body's parts. You can organoid of liver, organoid, different kidney, and that's something that you can do for research. So that's one of the very exciting part in the lung. This is, for example, this illustration. So how do you get the organoid from alveoli? You infected with virus, COVID virus, and you can do your study on them. So that's to summarize this part of the regeneration. You can see the saccular part and the regeneration part. Now, those beside the organoid are giving stem cell therapy are given intravenously. And those stem cells can be embryonic stem cell, that the polypotent cell that they can really transform to any other cell. That you have stem cell therapy for everything, for joint disease, for lung, for so forth. And you have stem cell that can generate type 2 cell. And they can keep mesenchymal cell or epithelial endothelial progenitor cell. And you can take them from the person itself, from the bone marrow, or from the fat tissue, or from the umbilical cord. So you can take those umbilical cord, you can take in general, but if you want to treat the patient with a stem cell, you take from that patient, you take from his fat, and you transform it into the stem cell that you want to put to the lung, to the joint, to whatever you want to do, to the heart, whatever you want to put the stem cell to work. That's a very exciting. Now, does it work? Well, these studies here, in many of them are done obviously in mice, but in human, they're very limited real data to support that this so far at this point work. So that study, for example, 262 patients, they looked at following them for 52 weeks of treatment, and they didn't find any benefit of the lung function with the stem cell. This is a study that came from England, and what they did, they actually looked at mesenchymal cell that they put in the lung, and from bone marrow from the patient, and they followed them for 2 years. So they give treatment for 4 months, okay, 62 patients for 4 months, and they follow them for 2 years to see if there's any improvement in the quality of life, in any improvement in exercise capacity, any improvement in the inflammatory factor, any improvement in spirometry, or the need for oxygen, and they find they didn't make no difference between the group that got placebo and between the group that got the stem cell. So at this point, the jury is still out. There's not really a definitive answer to this, but that doesn't stop a lot of places around the world. This is a place happy to be in Thailand, to advertise for you therapy for COPD, therapy, and they are costly, like $20,000, $30,000 a treatment. And they all in very exotic places. And they, for example, show the lung before, and this is after. You can see how the cell regenerated. However, it's hard to see if this is really scientific data really published in any respectable journal. And you can see that we have all over all these places, like in Panama, in Mexico, Cayman Island, Grand Cayman, and so forth, all these places. Now, be aware that the FDA only approve, the only thing the FDA approve is blood forming stem cells. They're the only thing approved by the FDA. And the FDA actually warned people against going stem cell before they really may do their research, because they can be potentially harmful. In fact, they said if they told you that it is your blood, so the FDA doesn't need to approve it, that's not true. if they do have to approve. And if you do it out in the United States, look for the investigational IRB protocol confirmation. Look at in all this data careful. If you go outside, the FDA cannot really protect you against and doesn't control the thing outside. So there's a lot of warning about it. But it is very exciting that maybe in the future, we as anesthesiologists will be involved, especially with organoid, in transplant those organoids inside. Now, the second subject I'm going to go to talk is about the lung on a chip. Now, what is this lung on a chip? What exactly I'm talking about? Lung on a chip, it's like a microchip they manufacture, you know, for the different part of electronic part. And it has inside a live lung tissue that have liquid, with the blood and air in those channels. And you can conduct all the research on this chip that is very confined. So this is the chip. This is lung on a chip. This is a live tissue inside this. And all this is the blue is in the air part, and red is the blood part that going. So if you cross section this area here, what it consists of a layer of air, the layer of the membrane, and blood for one side, and then two vacuum. I'll show you what the two vacuum are, and you can see it here. This lung on a chip, and you can see the airflow up here, the membrane of the epithelial cell and the capillary cell, and the blood flow going down the capillary, epithelial in the air. So this is really a lung between capillary and alveolar. And this two vacuum here, what it does is expand the lung to stretch it, to give it the exact effect of breathing. And this area here, this part here are attached to this knob here that supply the blood, the air, whatever you need to do the study. And you can see it even better here. You can see the air part, the blood part, the vacuum, and it's really assemble the normal and the stretching during inspiration in the lungs. So they can read it. So what is it about? What is it good for? Now you can see it here. You can see here, for example, the neutrophil inside the lung on the chip. There are the responsive neutrophil to bacterial infection, and you can see all this neutrophil going around the bacteria. This is, for example, you can see that the white cell attack the white cell that you can see them here in blue, attack the bacteria, which is in yellow, okay, into the alveolar lung chip. And this is, for example, a sample of ciliate cell airway that perform the mucociliary clearance of secretion, like you do in a normal body. So you can see this lung can behave, this lung on the chip can behave like a lung, like a normal lung. And you can, so what is good about? What is good about it, so you can really take those and you can potentially create different part of the lung. So it doesn't have to be only alveolar lung. That can be also nasal or pleura, and you can develop different part of the lung. For example, you can have nose on a chip. Now, what is the nose on a chip? Nose on a chip, you can study rhinitis, you can study allergic part of it on the nose on the chip. So you can really focus on one part on the nose and the chip. You can have trachea on a chip. So you can look at the mechanism of tracheal stenosis, tracheomalacia, or other disorder, or can even look at the long-term effect of positive pressure ventilation, very controlled, in a controlled manner. Now, you can there take those and you treat organ, you can have not only lung on a chip, but you can have other organ on a chip. Now, the thing that criticized this is to say that you cannot just look at one thing because you don't know what the reaction of the other part of the organ of the body will react to this specific thing. Let's say medication that you want to give. How the liver reacts to the lung bronchodilator you are studying on the lung on the chip. So you can create different organ on a chip and you interconnect them. So you can have, today they have, for example, again, kidney on a chip, liver on a chip, pancreas on a chip, and so forth. You can have all those on a chip and connect them, and we'll end up with some kind of the future human on a chip. Now we have human on a chip, so we can have the lung on a chip, test some medication, chemotherapy, or a kind of treatment, or stretch it, or create inflammatory factor, and you can see, because it's a human chip, it's connected to also to other part, you can see how they react. This is like an amazing part of research that basically allow you to research certain things specifically. You don't have to go through animal research and spend a lot of money and spend a lot of this time, because this is a lot of other factor going. Can you hear me? Okay. A lot of other factor going in. So this is very focused on type of research. So let me continue here on the last part, which would be, so we looked at this, all this, what is available, the one that I want to talk about, the last part of the lecture, is lung regeneration. In other words, lung bioengineering. Now, what is it about? What is it all about? Lung bioengineering is, as you know, in the United States, there's many, several thousand waiting at any given time for lung transplant. About 1,400 people in the US at any given time. Mainly COPD, cystic fibrosis, and so forth, especially young people, cystic fibrosis. Unfortunately, 20 to 25% of those people waiting on the list will die before you would get the lung, one. Two, as you know, all of you involved in lung transplant, it's very, very complicated procedure. Many times the people come back with the immunosuppression, the lung reject, a lot of infection, and so forth. It's not such a benign procedure. Graft failure is very high rate. So one of the obstacles is, imagine if you need a lung, you specifically need a lung, I can create a lung just to create lung on demand for you. Now, what does that mean? So I can create lung that will be just for you from your cells. That means that you would not need any post-transplantation immunosuppression because of your cells. So let's go and see what exactly I'm talking about, okay? Let's go here. Okay, so you remember probably from April, not last April, April before, it's 78, you remember that some scientists in Israel, they produced a heart they took cells, stem cells, and they put it all together to make it endothelial heart cells, cardiac cells, and they use a three-dimensional printer in order to print a heart. Because they put a simple heart to one side, the three-dimensional printer reproduce this heart, and you can see it right here. This is a heart that came from just stem cells, and this heart is pumping. So in the future, you can just take this heart, and if you can create a human heart, this is a small size, and you can put some pacemaker for the conducting system, you can have a heart that can produce from the patient's cells. You take a fat cell, as I told you before, for the stem cell, engineering to be cardiac cell engineering, and then You put them all together in a bioreactor and so forth, and you do that. But this is not our topic. Our topic today is the same principle, is the lung. So what they do, you need a scaphoid, first of all. You need to create a lung, you need a scaphoid, some skeleton that the lung will be on. Okay, it's 3D organ. Then you have to put it all in put cells there, dress them with, take all the cells from that lung and dress it with a new cell. So what's the idea? So you have a lung, then you take away all the cells from the lung, put into this lung all kind of vascular endothelium, pulmonary epithelium, blood, air, and you create a new lung. So let's go over the way the system works. So first of all, you take a lung, and that's the key. You take a lung that you throw away. In other words, you have a donor. That donor lung is not good. You're not going to use this donor lung. It's, because a lot of lung, over 50% of them are not used for damage because they're very sensitive. So you take a lung that you throw away. And what you do, you denude this lung. You put a detergent with sugar. And this detergent clean all the cells, all the epithelial and the all the cells, the blood cells, and the capillary cell and the endothelial cell. Just leave the collagen, just a skeleton of collagen with no other stuff. Now this collagen is not reactive because all of us here on this meeting now have the same collagen 2 type. So it's not reactive. It doesn't matter if I give it to you or not. It's not immunely reactive to anything. And then the sugar keep the elastin protein that later on we will repopulate the lung. This cells can attach to the skeleton. That's why we have the sugar. So this is the lung after you took away, you denuded the lung from all the cells, the capillary endothelial cell. It's just a skeleton of collagen. And if you go in with fiber optic bronchoscopy, you can see the normal structure of the bronchus with the division and so forth. So you have the skeleton right there, but it's nude. There is nothing on it. There's no cell, there's no blood cell, and no epithelial cell, just the base of the skeleton. Now, once you do that, on this you have to populate the skeleton. So you take cells from the patient, and you just, again, you need to have enough cell to cover almost 100 square feet, and you basically recreate from those cells, again, endothelial cell, and the stem cell engineer them to be airway cells and capillary cells. And the same thing, then you put them in a bioreactor. And the bioreactor gives them all the nutrient, and when you repopulate this lung, and you monitor the organ for perfusion and ventilation. So those are the bioreactor that the lung is in. And those bioreactor, you put blood, air, nutrient, you remove the discard, all this, and they basically, the lung grow for several months inside this bioreactor. And now you repopulate again the lung. Here's the cells again in the lung, you put them back in. Those are the cells. But the difference is, those are the cells from the person who's gonna get that lung. So once this lung will mature and be ready, you don't need to give any more immunosuppression of any sort, because this is your own cell. So this is the lung, this happens to be a rat. You take the lung before, and look at the lung again. You repopulate, after you denude, you repopulate it again. So you can see also the peak airway pressure, because you have a good peak airway pressure. Now here, the lung is stiffer. When you take away all the cells, why? Because the type 2 cells are not existing anymore. You washed everything, you denuded the lung. so you have no surfactant. So the lung is much stiffer to ventilation. When you re-engineer the lung, when you redress this lung again, repopulate the lung again with the cells of the capillary endothelial cell, it returned to almost normal pressure volume control. And this is the lung that I showed you before after you repopulate. Look at the lung look pink again, and you can measure the tidal volume, the peak airway pressure in this lung, and see how it changed in progress with time since the time you denuded it. And that's the lung after you denuded, and the lung after you repopulated it with, again, cells that come from the person who's gonna have this lung transplanted in. So the process basically is you take a lung, damaged lung you don't need, okay, you don't need it all, you denuded the lung, you decellularize the lung, take all the cells, and you can see the bronchoscopy, you remain the skeleton. The skeleton is the same collagen that is keep the normal bronchoscopic, endoscopic, bronchial tree structure. And then you put them into a bioreactor. You add to this vascular endothelial pulmonary endothelium, so vascular, pulmonary, you perfuse the lung with blood, you connect the ventilator to give oxygen, and you, at this point, you re-cellularize the lung. And the lung becomes pink again when it's ready, and you transplant the lung in the person or the animal that you want to use. But there are two people in the United States, one, Laura Lockerson, she's from Yale, and another person from Galveston in Texas. They are very advanced research in this subject. And by the time she presented that, they had a rabbit that transplanted this lung in the rabbit, and the rabbit was alive 2 months after the transplantation. That it didn't die at the time of the transplant. Just with the time, 2 months, was maintained with lung that was totally bioengineering from another donor. So the lung is, as you see, is a very complicated organ. This is the microcirculation. You can see the red cells going around the alveoli, gas exchange, and it's not a simple organ to mimic, but it looks like we're making progress with a lot of areas that we can really, maybe in the future, help a lot of people with COPD. Maybe the best thing is to just try to convince our patient to stop smoking. That would be one of the preventive, maybe population health, rather than to begin with, to try to find the solution with transplant or regeneration. This is me and Mert in Hagia Sophia, when I was there 10 years ago, visited together in Istanbul, and we had nice dinner. This was Mert's wife and George della Rocca from Italy, and we went to one of these restaurants. You have to go with the boat to transfer to the other part of Istanbul, to the Asian part, I think, of Istanbul, and we have a very nice time. I do want to invite you this weekend, actually, this coming Saturday, not tomorrow, a week from today, from tomorrow. We're going to have the PGA, the Postgraduate Assembly, unfortunately, going to be virtual in Zoom. It's Saturday, Sunday. This year, the 74th annual meeting. I'm actually going to give a lecture there on cryogenic pressure, believe it or not. And next year, we have the 75th anniversary of the PGA in next December. We're going to have a big celebration. Hopefully, we can do it in person, and we're all invited. As well, we're going to have a the 7th Thoracic Symposium in the PGA in December 9 and 10, 21 in New York City. It's a day and a half of thoracic just during the time of the PGA. Hopefully, it's going to be much different time and we can all be enjoying. This is to show you That part of, you can see, this is one of the ESA meetings that we were, with Mert and Thomas Hackberg and Manuel Granel from Valencia. He's always put a beautiful meeting that we can go. I go for the tacos, to have a nice tapas in Valencia, and Mark Miller and the Gamadan Brew and so forth. It's a very nice group, and you're all invited to our workshop. Okay, thank you very much for listening. And if you have any question, I hope you enjoyed the lecture.
Thank you very much, Edmond. That was.
You're back. I didn't see you. You're back.
You see me?
Yeah, I see you now. Okay.
Okay. Thank you very much. That was yes. I couldn't watch it until the end in the smart because there has been a disconnection, and I was worried until the last minute whether there would be a disconnection too. But it appears that our internet is somehow better than the one in Italy. But okay, and that was indeed exciting, and it was also very good for me because I couldn't listen it until the end. As I said before, let me say it again in English, in Turkish. Sorularınız varsa lütfen chat box'tan buraya yazarsanız çok sevinirim arkadaşlar. If you have any questions, please write down your questions in the chat box so that I can moderate and I can direct them to Professor Cohen. Edmond, what is actually the future aspect here? So we will see in our lifetime that there will be these synthetic lungs transplanted into the patients routinely.
You know, I'll tell you, they're already producing a human lung. Lara Nicholson, she's actually, again, she is an interesting person. She has, you know, trachea reconstruction is already clinical, right? Trachea of the back, the transplant like trachea already. She is actually an anesthesiologist and also a professor of bioengineering. She had together an institute that produced vascular pieces. You can produce vein and artery with a patient who need bypass. You know, so you don't need to put a plaster, you know, Gore-Tex or take your own vein. You can produce artery. So this is already FDA approved, and it's done already as human, produced from your own cells to produce it. And she running this. I say your wife is back.
Yes, she's there.
Say hello to me. From me. So bye. So she now, Ralph Nicholson is really at the front of this research. She was actually, we were supposed to be on my panel at the ASA in Washington. That was virtual, so we didn't do it. But the next year, she will be in San Diego. The American Society of Anesthesiology is going to be in San Diego, and she's going to be one of the panelists. And what the latest I know is not going to be, you know, very near future. I don't want to put a time frame and number, but they're doing an animal. They're already able to keep the animal with lung that is produced from a lung that you throw away for several months, which is very exciting. I think that's the first step. The same thing with the heart. You see the tri-dimensional heart. They took a heart. This is a pumping heart that just produced from fat cell. That basically was stems were bioengineered to be cardiac cells. And the thought is, it would be difficult to produce Purkinje system and the conducting system, but you're going to have a heart that you can put in a leadless pacemaker, that you do, and you can have a pumping heart. So
Uh-huh.
lung, I can't tell, I can't give you a number, but I think the research is very promising. Of course, the one of the whole idea is that we can overcome the shortage of organ and overcome the fact that you don't need to give immunotherapy, immunosuppression. That's the rate with this. Some people come 20 times back to the operating room after lung transplant because they have all this complication of any sort. So I think that's very, very exciting.
Yes, indeed. Another question I have here from Mukadder. She's been with Ancestor a long time. She's asking, has anybody looked at the effects of anesthetics on these new bioengineered lungs? And I can add maybe also these cheap lungs too, lung chip.
Chip. Well, the lung on a chip, yes, the lung on a chip. They're trying to do. There are some studies that look at different inhaled anesthetic. They look at different drugs, but I don't know if I think that in terms of the bioengineer lung, it's way too early to do the study. They're not in the. They are now. You see, we just talked about type A, type 1, and type 2 cells. But as I said, there are more than 30 type cells in the lung and different type of function and so forth. And the interaction in the lung is much more complicated than we think. So it's not, at that point, they're just trying to see if they're able to produce a lung that will stay and maintain the basic function of the lung. You know, the lung have many other function, non-respiratory function, of course. So that's very easy, very difficult to study. That's why you study those on lung on a chip.
Uh-huh.
It's easier to isolate on lung on a chip to direct your research. Let me go back to show your wife. This is another picture that we have together in, I think, in Spain, if I'm not wrong. But I want to show your wife here she is. I hope she'll enjoy a picture right there. She came in. So, what's the name of this one? I forgot.
Zerrin, she's also here now.
Oh, okay. I'm sorry. I couldn't remember her name. I apologize. But she's been with us many times.
Yes.
And I see Manuel. Manuel is here. How is Valencia, Manuel?
Hello. How are you? We are
good.
Very
Here
well.
in New York, I mean to tell you, we were doing very well, and now things going bad again in New York. I mean, we're doing very well for the country in terms of all the country, but now in New York, it's starting to go back again. But as I said, we just got an email that we're going to give December 15. We're going to get the vaccine coming, and I told Mert before they're going to give it first to the emergency room and the ICU people. As I said, anesthesia is not considered front line for some reason.
Excellent talk, Edmond. Very. Thank you very much.
We'll do it in Valencia.
We are working hard, but we are preparing for the Christmas time. But I think we are going for a next time better than last month. But I think we understand and we know a lot of things about the COVID problem. And I think the second wave is so different. It's much better than the first.
Yeah.
But you have a high number as well in Spain, no? You have a high number of COVID in Spain.
Yes, but not so high than the first wave, and not so critical situation for our patients.
It's totally inverse here. The first wave was quite well, but the second wave is much worse, very worse.
Really interesting. Because I thought most of the people said the second wave is not so. It's mainly attack younger people.
No, yes, it's attacking younger people. Our colleagues are in ICUs, also doctors and nurses, health personnel. That's bad. We can come back to COVID, but I have here two more questions. One
Yes,
from
go ahead.
Turkey, one from Maria Jose Jimenez.
Oh, Maria, yes, sure.
Yes, first I am asking her question, literally. This remember me a NASA program, and in another hand, also remember the first tracheal transplant with stem cells that Dr. Macchiarini made years ago without success. Why? When you think we can only find this exciting was a reality? She asks. So,
Sorry.
yeah,
Yeah,
here.
Maria, how are you? What's the question? I show a picture of you here, right here. Right?
Yeah.
You are?
Right. Yeah. I am here. Yes, of course.
Yeah, I mean, the
miss you
tracheal
always.
cell, you know, they did that actually. The first time I think they did it in England, isn't that? For a young guy, it's a 11 years old kid that they put a tracheal, they put stem cell in the tracheal, they
Yeah,
transferred the tracheal to him. Isn't it the
yeah.
first case?
It's a
That was the
very
first time they did it, but there was the same technique.
yeah. It's similar technique.
Go
It's
ahead, I'm
a
listening.
very.
Teach us.
You are listening me?
Yes.
You can hear me? Yes. You can hear me?
I can't.
Edmond?
I can't. I can hear you. I can hear you.
We can see and hear you, Maria Jose.
Okay.
Good.
Okay. So this is a very, very nice idea. A very years ago, there are 8 years ago, that is like a dream. And you can believe in it, but after it's a very special surgeon and man with a very nice ideas, but these ideas doesn't work. And okay, finally it's a disaster for some people that give this trachea made with stem cells. And it remembered me that this is a similar technique. I know that it's different, but okay, do you think that we in a future, because I don't think that now we can access to this experimental work.
Yes.
When do you think that we can
Okay,
we can
Maria,
get this technique?
I'll tell you what.
Okay.
I'll tell you what. First of all, I would never commit to time frame. I'm not going to tell you 1 year, 2 year, 10 years. I'm not going to do that. That I don't have a magic ball to tell you that. But I believe that yes. We will probably. I mean, look, I looked at some more of the studies they're doing, like in Israel with the heart. It's amazing. This is what they showed 2 years ago. They have now much more. They produce larger heart that I showed before, much larger and more effective. They stay for a while. And I believe that the lung with the quite research every day was look at organoid, and they will probably will put all this together, lung on a chip, organoid and regeneration. They connect it all together to be able to produce some kind of an organ that can help people without, because look at all these people who are dying. Look at all these people with COPD. You know how much it costs to the health system, the COPD patient? I mean, those patients, with COPD, need so much care, and most of them debilitated with oxygen. Look, for example, at the valve, right? If you ask me, I started research on the aspiration valve years back, it in to endoscopic to get emphysema, and people said it's not going to work. It's not. And so the first valve they put in, they got all with secretion. They have to remove them. And it was a whole headache with this. And then we did desperation. It looked like an umbrella. Initially, it was approved by Olympus just for continuous air leak. But then now it was approval. Now we have patients that before were not able to go from here to the bed. And now they're telling you about their intimate life. I'm not going to tell you what kind of intimate life. About intimate life they never enjoyed before, or they never been able to travel on the plane before to see their family because they couldn't walk. And now they walk with this, and you know, things change. And I believe that in the future, we will be able to have lung that we can re-engineer and put it in. Obviously, nothing is simple. Look, even the first heart transplant, right? Do you know that the first 256, the first two, since Barnard made the first heart transplant, the first 256 patients died within a year, less than a year. The first one, because we don't have cyclosporine, we didn't have Teva, and so forth. But I think that inevitable that we'll get better and better and better with time. I hope so.
Yes, yes. I hope so. I hope so. I hope
You
so.
retired,
It's very,
Maria?
very, very interesting, but for me now it's like a dream.
Okay. Did you retire, Maria?
Yes, of course. Not
No, so
completely,
you
but
said
a
that
little
you
bit.
said on chat that you were retiring. I envy you. You see, I envy you. Any other question, Matt?
Yes, we have one more question. If
Okay.
Then I will have also another question, but first the question from Tülin Öztürk. She is the next president of the Turkish IAKTA. In which one is the mesenchymal cell therapy more successful? She asks. Is it the interstitial lung disease or alveolar disease?
It's usually the alveolar disease is better than the interstitial disease so far. But again, the human study did not approve. There are no studies, maybe there are now, I don't know, to my knowledge, that are really effective. Those are the study, the result are done usually in mice, not in humans.
I see, okay. My question is maybe a stupid one, but okay, we recreate or regenerate the lung, you can see. How about the vasculature? Is the vasculature also growing or generating by itself around the lung, or do we have to do something?
No, the vascular in the lung itself, because you see, it's reorganized by itself. The endothelial cell and the capillary cell around will organize itself. Will not be. It's not. It's the stem cell that you engineer to be either capillary or endothelial for alveolar will reorganize themselves to do that. That's what they do. And so far, I did not see any human lung transplant yet. I don't think they did it yet, but they did it in rabbit. And it's working rabbit, not in human so far. But again, this is like really, I'm talking about, futuristic thing that we have to, I mean, I didn't know much about lung on a chip, for example. If you ask Maria, did you ever hear about lung on a chip?
Oh, I like it.
You never, I mean, if you ask somebody, and you never heard about it several years ago, and now you find out there are laboratories that putting human on the chip. They're putting a lot of pieces.
Yeah. This is true. I think this is the future of experimental way. No, is just you don't need any animal. You can reproduce everything that you want. So I think
you can direct. Really, it's basically dissecting. It's like dissected research. You focus. You take and you micro dissect the research to one area that you want to look at, without having interference for other 20 different side effects. So you can really focus on one thing and get the result of one thing.
Right.
Yeah. I am agree absolutely with you, and I found I hope that you can have a lung on a chip in a very short time.
Bert, when was that? You look like you lost weight here, isn't it?
Yes, that was the thing that I have said just to my wife. How I look so handsome, so thin. These were the days. With COVID, I get thicker and thicker. Edmond,
Okay, so hopefully some of you would come to the 75th PGA in next year. It will be alive
yes, this
in
time
person.
in person. We hope. We hope.
But you see, I'm in Istanbul. As you see, I'm in Istanbul now.
Yes, okay. Even
Yeah.
and
Istanbul,
in the
please.
background with the skyscrapers. Okay, can you show
All right.
this slide with lung on a chip again?
What is that?
The lung.
This is in Hagia Sophia, right?
Yes, okay, but I just wanted to see and show the people again the lung on the chip.
Lung on a chip?
Yes, can you come back? This is very interesting. This one. Here we are, lung on a chip. So,
This is lung on a chip, and then you can see this. The red one is the blood. The blue one is the air, and all this port is where you connect to put the blood, the air, and so forth. And what it has, if you cut it in this area, if I transect it here, you can see that basically it has the air part compartment, the blood compartment, and the membrane, and the two vacuum to create expansion. And you can see it better here. This is the epithelium, and this is the capillary cell, blood on one side, air on one side, that they can put them through this hole, through this entrance part, and then that's the way it look, and then they do the vacuum in order to expand it. This is right, and then they stretch it. So they mimic exactly the shear force, the mechanical force that go on the epithelium in inspiration and expiration. And then you can here you can see the vacuum, and this is the membrane. And there are three different membrane here that they put together, how they put them. And you can buy, actually those are lung on the chip. They're companies, you can just buy them. They're companies that sell it to you.
Can we consider it as an intelligent ECMO or something like this?
Oh my, I think that's too small for that at the moment. I think what you can do now, all they're doing now is doing concentrated research. You don't need, you don't need animal model. You don't need IRB for that. You don't need a lot of things. You can go and just see. But this is amazing. If you look at this, look at this. This is in the lung on the chip. They pass the membrane. Those the cells pass through the membrane from the out to the and then they really attack the bacteria. And you can see here how if you have the celiac cell in the lung of the chip moving to clear all the secretion, the clearance of the lung, like happened with the normal lung. And this is amazing. And this is on a chip. This is how you can maintain vital organ on a chip. Now, think about the possibilities. It's enormous possibilities you can have if you take a lung and liver and this all the organ, and you can have a human on a chip. You connect it together, and you can do all the research how giving one drug will affect the other organ and vice versa. I mean, the opportunity is enormous here. And then, as I told you before here, that we are not really confined to, you can have nose on a chip. Now that's exciting. You have all these people who have allergies. and they can rhinitis and all this. How many people have a colon? You can try to focus on that, or tracking on the chip. You can see why why do you have tracheomalacia, why you develop tracheal stenosis with intubation. So you can see the mechanism. If you develop tracheal, so you can have different part, also pleura, there are pleura on the chip. A lot of medication, like for example, if you're going to have any kind of mesothelioma, right? It's pleura on the chip. And you can do all the experiment to see why it develops mesothelioma or not. I mean, the possibility are enormous.
Okay.
Okay.
That was great, Edmond. Thank you very
Thank you
much.
very much. It was nice seeing you. Nice to see your wife, of course, Evelyn. You know, that's the best part. Nice to see you, Maria. And Manuel, send my regards to Lourdes.
Yeah.
Okay, and maybe we'll do it again in another topic.
Yes, that will going on. So both from the Anestezistanbul side and also from the thoracic side. We go on like this. This is the good part. This is the only good part of this virtual meeting thing, I think.
Yeah,
okay.
that was actually interesting that you know, when we did the ESA meeting, we have one person from Istanbul, Mert, and then we have another person from Marseille, from southern France, and another one from Belgium, and another one from Leeds, from England. And I was sitting here in New York. It's like a different world. Okay, have a good weekend, all of you.
Good.
And thank for it's a pleasure
Thank
seeing
you.
you. Bye bye.
Thank you so
Bye-bye.
much.
Bye.
Bye
See
bye.
you.
Bye.
Arkadaşlar iyi akşamlar diliyoruz. Teşekkür ederiz katılanlara. Görüşmek üzere. Bye.
Edmond. Era una